Welcome to the Georgetown Lancet Commission on Faith, Trust, and Health webinar series. This particular webinar is on faith-based systems building trust in Sub-Saharan Africa. My name is Nate Smith. I serve as one of the commissioners on the Georgetown Lancet Commission on Faith, Trust, and Health. This commission brings together experts and leaders from the global north and the global south, and together we have been considering ways of building trust between faith communities and healthcare providers and public health institutions. Today, our focus is on faith-based health systems building trust in Sub-Saharan Africa. This is a topic that's of particular interest to me. I serve as an executive pastor now, but previously I trained in infectious diseases, served for several years at a mission hospital in Kenya, and then later served as acting director of CDC's Center for Global Health. As part of the remarks from our panelists, we'll also be talking about a very timely issue, which is the Ebola outbreak in DRC and Uganda that's ongoing. One of the aspects of that is religious practices around funerals and burials. From previous Ebola outbreaks, we've learned how important it is to understand these religious practices and to engage with trusted local religious leaders to help control these outbreaks. So this issue of faith, trust, and health is very timely with regard to this ongoing outbreak. We have several distinguished speakers that I'll be introducing in just a moment. The first is Ibrahim Bola Gobir, who is the CEO at Georgetown Global Health Nigeria, and also serves as associate professor at Georgetown University. Our second speaker will be Emanuela Parotto, who's a clinical consultant at CUAMM, or Doctors with Africa. And our third speaker will be Nkatha Njeru, who is the CEO at Africa Christian Health Association Platform. And then our final speaker will be Yach, who's the Global Health Advisor at CMMB, Catholic Medical Mission Board. Each of these panelists have prepared brief presentations, and then we will move to a time where we'll hear from you and get questions for our panelists. So without any further delay, I would like to introduce our first panelist, Dr. Gobir.
Thank you, Nate. As we say in Islam, Assalamu alaikum wa rahmatullahi wa barakatuh, which is just basically means peace be upon everyone. My name is Ibrahim Bola Gobir, and I'll be talking about faith, health, and trust from the Islamic faith perspective, and then I will dovetail into specific examples, at least for Nigeria. Next slide, please. So again, just in terms of a little bit of background information with regards to population of Muslim globally. And then most importantly is to also see the distribution of the Islamic faith in Nigeria, with predominantly with a large predominance in the northern part of the country, as we can see on the map in areas highlighted in green. And within the Islamic faith sector, we have different existing community networks ranging from Islamic schools to informal congregations, and some of them have been able to formalize their structures to even the mosque itself. These are trusted structures that are able to reach a lot of people on a daily basis. And these networks operate on the principle of do not, throw yourself into destruction with your own hands, which is basically a citation from the Quran. Next slide. I try to use this as an example of, something that is not far-fetched. I came up with this particular comic whereby a child who is already been introduced into doing ablution to perform prayers, which is basically, you wash up yourself a little bit and then you go and perform prayers during an Ebola outbreak. And then the mother was able to use that opportunity to actually talk to the child about, putting salt in that water that we use for ablution and then bathing. And typically what the mother basically was saying is, this is something that was going to protect the child from Ebola. Now, the reality of the matter is this actually even happened to me. So I'm actually the child in this question. And this happened during the Ebola outbreak. I think the one in 20, the last one that we had where we had soya in Nigeria. And my mother actually called me as a doctor to tell me the same thing, to say that, have you done this morning? Have you prayed? And I said, yes, no, I'm about to pray. And she literally said, okay, before you pray, recite a few verses from the Quran into that water that you want to use for doing ablution, and then you can use that to bathe yourself, and then you can go ahead and pray. And when I asked her where did she get this information from, of course, she says she got it from, a network of for an informal Islamic gathering. And for me, that kind of just resonated with me whenever you're talking about the impact on faith in terms of sharing information out there. Next slide, please. So when we talk about faith itself, there are a lot of structures on ground that within the Islamic faith, it ranges from having imams. Imams are actually those leaders who actually lead prayers. These imams are present in the mosque. Within the mosque, there are others that are also that are not necessarily imams, but they also contribute to driving the Islamic faith. These are structures that exist within the community. But the structures alone are not enough to drive what we're talking about with regards to a health system or supporting community system. What drives it is actually the trust that people have in a lot of these in a lot of these faith leaders. With trust, once trust exists, which is basically what the the faith leaders in the Islamic sector have been able to use, it facilitates community acceptance, community cooperation, adherence, and reporting, which invariably, of course, leads into improved health outcomes. And I will be citing specific example quickly around some of the health outcomes of interest with examples basically from Nigeria. Next slide, please. So I'd already talked about this earlier with regards to the different networks that we have within the Islamic faith, from the mosque, the Quranic school, the community structures, as well as fellowships or informal fellowship that we've had in Nigeria. Again, the unifying factor here is actually trust, because what is resident here across all of these networks are largely you are looking at the trust that they are able to bring, and that trust is what they've been able to use, to communicate in all of these different networks, ranging from the Quranic school itself to the mosque when you have all of this conversation, and then even to the fellowship as well as community structures. With this, okay, it enabled the network to be able to communicate faster, mobilize a lot of people, educate, as well as also provide social support. Next slide, please. So in terms of Islamic principle that support public health, we have some of these, and again, maybe one of them is particularly critical and important when you're talking about Ebola. So generally, the principle that reinforces public health starts from preservation of life to seeking treatment to preventing harm, as well as collective responsibility of supporting the community. But most importantly, some of the practices in Islam that ranges from ablution when we want to pray, where you have to wash your hand, your face, your feet, to even fasting during the month of Ramadan, to avoidance from harmful substances like alcohol and the rest, to even zakat, which speaks to harms, and then the earlier burial. Now, earlier burial is the one that I probably want to hold on to for in this particular instance, especially if you're looking at outbreak. We used to crack a joke that in Islam, if somebody just make the mistake to kind of just drift or you doze off, if you try to wake you a couple of times and you don't wake up, you've long been buried. That's not necessarily true. At least you try to ascertain that the person is really dead. But the principle for Islam is largely early burial, and you do a dignifying burial, which again, if somebody is looking at it in the context of the Ebola outbreak, right, at this particular point in time, it makes it a lot easier to actually be able to communicate or leverage these Islamic scholars in driving, introducing infection control into whatever they really need to do with regards to burying. Burying somebody early is usually a challenge generally in most part of Africa and even in Nigeria, but with Islamic faith, it's just a layer on to say, hey, you perhaps just need to introduce a little bit of IPC into, or infection prevention and control, into what you do for you to potentially be able to actually bury this person, since the principle already allow for early burial to take place. Next slide, please. So the last set of examples that I really want to give with regards to Nigeria is the polio eradication example, as well as COVID-19 response. Now, both of them are viral infections, and both of them also have something in common, which is deployment of vaccines. For a state, for example, in Nigeria, the Kano state, there was a particular instance where, there was vaccine that was introduced for meningitis, and that caused a lot of problems for the children that were under 5. And the faith leaders were rapidly able to go out there and, communicate or share information with the community on why people should move away from actually taking those vaccines. And that kind of just skyrocketed or snowballed into other potential vaccine preventable diseases. So with the polio, it was also a challenge because there was that initial kickback because the faith leaders have not necessarily gone back to communicate to the community and let them understand that this is different, But when the government was able to sort of just leverage the faith leaders, at least in a place like Kano, it was a lot easier for them to now, convince the community that you can go ahead and actually take on this vaccine. And the same thing with COVID. In Islam, there's a lot about congregational prayers. And for men, for example, you are not necessarily, it is recommended that most men should go out and pray in the mosque rather than praying alone. So by the time we're looking at social distancing and the rest of them, some of the Islamic leaders felt, you are basically just trying to tell us that we cannot have congregational prayers again. You want us to just stand alone and be praying when the recommendation from the Islamic faith is that we should congregate and pray to that, pray 5 times a day for men, especially if you can do that in the mosque. And suddenly you are not talking about, social distancing. And then come in, of course, the introduction of the vaccine. But then with the engagement of the faith leaders within the Islamic sector, letting them understand that this is the reason why we have to do this, it was a lot easier for them to actually go back and let the community know that this is not tied to the religion. We're not saying don't have your congregational prayer, but this is as part of protecting everyone. So what that taught us really is that trusted leaders accelerate acceptance, at least within the Nigerian context. Faith institutions amplify public health messaging, and community engagement through the faith leaders reduces resistance. Next slide, please. So I'll end my presentation here, or my opening remark here, by saying, at least from a Nigerian context perspective, people often listen to those who pray with them before those who prescribe with them. So you will see that when those faith actors start talking to the community about ill health, about public health intervention, people listen faster, even before those of us who are care providers. So it's to our own advantage if we can actually focus on working through this particular faith network to drive trust within the community. Thank you very much.
Thank you, Bola, for an excellent presentation. We'll move on for the sake of time to our next presenter, Emanuela. I turn it over to you.
Thank you very much, Nate, for the nice introduction, and good morning, good afternoon, everyone. In this short presentation, I'd like to share some insights regarding the strengths and vulnerabilities in faith-based health facilities. And I will present a multi-country assessment performed by an international organization named Doctors with Africa, CUAMM. For those who are, next slide, please. For those who are less familiar with this organization, I'd like to add some background information. Doctors with Africa CUAMM was founded in 1950, and it was the first non-governmental organization focused on healthcare to be recognized by the Italian government. CUAMM has a long-term meaning both in long-term missions, but also in situation of emergencies to ensure that the services are available to all, but particularly for the most vulnerable population. It performed its activities across 9 countries in Sub-Saharan Africa, Angola, Central African Republic, Ethiopia, Ivory Coast, Mozambique, Sierra Leone, South Sudan, Tanzania, and Uganda. And it performed and leads its activities through hospitals, districts, but also implementing universities and nursing and midwifery schools. It performed its activities thanks to the help of more than 3,000 healthcare workers across Sub-Saharan Africa. During its long-standing presence, CUAMM witnessed the key role played by faith-based organizations. Next slide, please. Faith-based organizations have historically played a pivotal role in healthcare delivery, and this is well recognized in the global health arena. Estimates indicated that FBOs deliver between 30 and 70% of healthcare in many sub-Saharan African countries. And these organizations are widely recognized as trusted community actors because thanks to their long-standing relationship and thanks to shared values with communities, they shape care-seeking behaviors, enhance adherence, and sustain service utilization. Given these important pillars, recent global health analysis highlighted trust as a key determinant of health system performance, influencing both individual engagement and broader system legitimacy. Recognize this key role played by faith-based health organizations. Next slide, please. CUAMM launched in 2019 an initiative aimed at supporting a faith-based organization delivering healthcare in Africa, with the aim to strengthen the capacity and resilience of FBOs managing health facilities in several African countries. Next slide, please. The core activities of this initiative were the following: training, because CUAMM aimed at develop and provide training packages to FBO staff. Moreover, CUAMM implemented field assessment missions with the objective to provide technical assistance to these healthcare facilities. And finally, CUAMM disseminated the work done with the objective to advocate for better integration with these healthcare facilities within the national healthcare system. Next slide, please. I'd like to focus my attention on the field assessment mission built to provide technical assistance to healthcare facilities. And these field assessment missions were conducted between November 2029 and 2021 and February 2024. They involved 11 countries and 63 health facilities managed by 48 different faith-based organizations. These assessment missions were based on questionnaires with a collection of both quantitative and qualitative data. And this mixed method data collection allow us to develop a broad view and in-depth understanding of these healthcare facilities. Our data concerned the health facilities features, let's say challenges, but also strengths, and also disaster preparedness assessment. Next slide, please. And the main findings revealed a misalignment between the strengths and the challenges experienced by the daily practice of these healthcare facilities. Several challenges negatively impacted the delivery of healthcare. Here you can see the main challenges concerning human resources, but also inadequate infrastructure and the lack of emergency preparedness plan. Also, the lack of data collection and adequate information system undermine the role of healthcare facilities and the ability of healthcare facilities to ensure care for the population. And one of the most emphasized challenges was the lack of integration and coordination within the national health system. On the other side, and despite these challenges, healthcare facilities managed by FBOs reported three main points of strength: their social embeddedness within the population and the trust from the local communities. Also, workforce commitment, because healthcare workers, despite difficult working conditions, showed a strong commitment to their work and their mission. And also, these healthcare facilities ensure the provision of healthcare in very remote areas, because they are, in many situations, the only source for the population to receiving healthcare and health assistance. So the findings of our missions revealed that and confirmed that FBOs are core system actors within healthcare system, but their potential is constrained primarily by under-integration within national health system. Therefore, strengthening the integration of FBO into national health system, meaning not only addressing structural gaps, but also enable policymakers to more effectively harness trust as a driver of access and quality of healthcare. And last slide, please. The concept of trust become very important in health emergencies because communities are more likely to seek care, engage with the surveillance system, and adopt preventive measures when they trust the institution leading the response. And this is particularly true in nowadays, given the occurrence of the Ebola outbreaks and epidemic in the Democratic Republic of Congo and in Uganda. Doctors with Africa CUAMM has activated an emergency preparedness and containment plan in its traditional areas of operation in Uganda, and this plan relied on trust of the communities in the health institution led by faith-based organization. Trust is a tool that allow the implementation of personal protective equipment and infection prevention controls, and also the adherence to public health intervention to control this epidemic. This was the last slide of my presentation. Thank you very much for the attention.
Thank you so much, Emanuela. Next, we'll hear from Dr. Njeru at ACHAP. Dr. Njeru, I turn it over to you.
Thank you very much, Nate. My name is Nkatha Njeru. I lead the team at the Africa Christian Health Associations platform, and I'm going to talk about how we have built credibility, community action, and resilience through trust in communities. Next slide, please. So one of our story on trust begins far beyond when we start to have action in communities. It begins with institutions that communities already know: mission hospitals, churches, schools that the previous speakers talked about. So we exist in 32 countries in Sub-Saharan Africa with 43 member Christian health associations, as they're called, who bring together up to 10,000 faith-based health facilities or mission hospitals, as they're commonly known. And we potentially reach up to 500 million people on the continent. And as you may know, in some countries, up to 70% of healthcare is provided by faith-based health systems. So between 30 and 70% of healthcare is provided by faith-based health systems in Sub-Saharan Africa. And up to 90% of Africans subscribe to religion. Next slide, please. And so how do we do this? We work with the assumption that trust moves through relationships from continental coordination to household level that reflects in what we do with individuals. So we have three specific things that we center on. We equip, connect, and amplify the work that is done by the faith-based health system on the continent. And so we create spaces where governments, donors, CHs, and faith leaders are able to align around national priorities. We also ensure that our membership is well equipped to do the work that they do. And we make sure that we amplify both at community level and at national level the work that is being done by the faith-based health system. And so that cascade, or being able to have a presence from continental level until the community level, has been helpful in creating trust. Next slide, please. So I'll talk about trust through presence. What I want to say is that the messenger is trusted because the institution has worked long before Ebola comes, long before there's a health crisis in the community. People have had a mission hospital that has existed for 100 years. There's a church where communities serve in the women group as women group leaders, as youth leaders. Families go to that church. And we have churches and hospitals and schools that have existed and are not temporary. Projects come and go, but these structures have lived there long before. And therefore, for those, the presence, the continuity, and the service that these structures have given them, have in our work, we have discovered that they have been one of the things that have been able to establish trust. Okay, next slide. Building on what I talked about trust through presence, and specifically talking about two specific pandemics that we have had in the near future, the Ebola pandemic that we are working on in DRC and Uganda, and COVID-19. One of the biggest challenges we've had to deal with is issues around misinformation, disinformation, and vaccine hesitancy. And one of the ways that we have found very helpful, but unfortunately, in many cases, faith-based health providers and health systems are called upon, not formally, but included later when things are already in motion. But we have come in and provided very good support to in emergencies and outbreaks, where there have been rumors and fear. We have used faith leaders as trusted risk communicators, because people come and they're worried, why can't we congregate in church anymore? And if it is the faith leader explaining and not the health worker or the Ministry of Health, the district or somebody announcing it as a new bylaw, then it becomes easier for communities to accept. Where we've had weak referrals, and we are doing this even with the current pandemic, we have used faith leaders as a link between the facility and the community, where we have done contact tracing by having a faith leader focal point at the facility who has the list of contacts that need to be traced. And we have mapped out faith places of worship and faith leaders in those areas and used them to reach out to the contacts that we need to reach out to. In times of, and especially like now when one of the biggest issues is around burials. And as you know, these burials are done by faith leaders. And therefore, when we use them and have engaged them as the people communicating why we need to have safe practices around burial practices, we have seen communities embrace. And so one of the things that has been expressed is being able to ensure that we still have dignified behavior change around the practices that are being recommended by health workers. And then, as you're aware, during emergencies like this, one of the other things that is forgotten is other services. So to ensure that there's no disruption of services, we use them, women group leaders, youth leaders in the church, to ensure that women who need to go for maternal and child health services get to those places. Next slide, please. The other thing that I need to say is that what we have noted is that trust is not just by appearing when people are in crisis. The fact that these services have existed in those communities and provided services during ordinary moments have built invisible trust. So, for example, we have brought reading glasses to communities, and because we used congregations and talked about, and people wanted to have reading glasses to be able to read their Bible, then we were able to distribute up to 1.6 million glasses by this year. We have gone to communities and reached zero-dose children. We have gone to communities and used faith leaders. So all the work I'm talking about is by using congregations and faith leaders as the focal points, and worked on stigma and discrimination. So just being there for communities during ordinary moments and taking care of their ordinary health issues has helped to create trust, so that, for example, you can imagine at this time, one of the things that might be overwhelming to communities in Ituri, North and South DRC, is a lot of, for lack of a better word, people they're referring to as strangers. But if you've existed in that community, then it gives reassurance to the community. Next slide, please. Then using trust as a bridge between government, partners, and communities. So we've been able to both do cascade policies down and take recommendations up at the national level to the decision makers by bringing realities of communities. And because rather than creating parallel systems, we exist in communities, we report in the systems that are there in provided by the government. We also help to translate what the government is saying, like I'm talking about, especially during this time of crisis. And also using, when policies are being made, making sure that we're seated at those tables and representing communities, so that whatever is being done is a representation of what communities would like to hear. And if it is not going to be easy to translate, then we make sure to do that. And the last one, next slide, is trust through interfaith collaboration. One of the things we try to make sure we do is that health challenges don't exist. There are no boundaries between denominations. Communities have Christians, they have Muslims, and other religions. And so we try to ensure that we work together. When we develop sermon guides, we work with all the faith leaders. We have a guide that has sermons from the Bible and from the Quran, Nkatha from the Quran. We also ensure that we are not confusing communities, because we make sure that we are working together so that those who are Muslims have somebody that can speak to them in a way that they can hear, and to ensure that there's cohesion in that community, and also to create credibility. Because sometimes one of the things we've had government saying is that there's a lot of, they don't know who to speak to when we say faith. But when we come together, for example, you see in Uganda and Kenya, we've come together and made sure that we are all speaking to the government as one voice. Next, please. So in conclusion, trust is infrastructure. The values that we have bring shape to trust. Partnership matters, and local institutions endure. And the last slide, next slide. I think that the future of resilient health systems in Africa will truly depend on not only on financing and technology, but also the trust that we have in the communities that we serve. Thank you.
Thank you, Nkatha. Thank you for your presentation. Next, let's move on to Derek's presentation. Derek, I turn it over to you, and then we'll have our time for question and answers.
Great, thanks, Nate, and a real privilege to join you all and to be with such an extraordinary panel who both bring their personal commitment and drive, as well as incredible technical competence. I'm meant to take a different perspective and really make the case that while so much work has been done in infectious diseases and maternal and child health, the real power of faith-based organizations could still be to come in terms of non-communicable diseases and mental health and their associated risks, not just because of the trust value that's associated with their services, but because the deep spiritual components of the great religions that could be deployed to have enormous benefits for many of these conditions. I do that being very aware that I'm a dual citizen of South Africa and the US, with my roots being in the past in a number of research projects and delivery services, which involved mission groups across rural South Africa. I then took a deviation turn for a decade to WHO and really believed that the documents we developed there would be able to be implemented very simply and rapidly at the community level, something which I know we heard has not happened. And I think what is striking from this is the gap between many governmental programs and the power of linking to faith-based organizations. So just a few comments on challenges and opportunities that we've already heard of. On the opportunity side, we've certainly heard from Nkatha and Ibrahim about the incredible reach of faith-based organizations, delivering maybe 30 to 50% of health services across the continent, reaching maybe 400 to 500 million people. Certainly within CMMB structures, they're aware that almost 80% of the over 700 facilities they serve are faith-based organizations across 11 countries. If we actually then say, well, what is the size of the opportunity? And I think we should just use two figures to keep at the back of our mind. Almost 90%, maybe more, of people in Africa that do not have easy access to mental health treatment. 90%. About 70% of people who are diagnosed with cancer across Africa get diagnosed at a stage that is non-curative, requiring either palliative or supportive care. Next slide. We've heard enough, and I'm not going to repeat it, about the enormous trust advantage that the faith-based organizations have. They've both been formal surveys. I think one of the evidence of trust was in the recent State Department commitment of almost $240 million to Caritas and faith-based organizations just announced this week. And if you read the press statement, the most interesting part to me is that their justification is because of the high trust quotient associated with faith-based organizations. That is something that we can and should build on even more, and build on as we start moving beyond AIDS and infectious diseases to address cancer and many other areas. I won't repeat the comments made about Ebola, just to note that with any progress or any positive aspect, there are always caveats. And here we know that the very holy rituals that we so support can and do fuel unholy outbreaks. And I think we've heard very careful, thoughtful ideas about how to limit it. I do want to give one brief reflection on the fact that we really need to build upon the fact that the notion of patient-centric health, human-centric health, holistic health, integrating health services, prevention and cure is not new. And in fact, it's been in the body of our religious leaders and their writings for well over 1,000 years. If you go to Islam, Avicenna, in his writing, stressed the fact that the soul and body are inseparable, and that has enormous implications way beyond infectious diseases. Maimonides, one of the great rabbis and physicians of the 12th century, stressed that bodily health was a religious obligation, both for the individual and then for the physician. And of course, he became the physician to Saladin the Great in Egypt, reminding us about the power of interfaith collaboration way back when. And of course, we learn about the work of St. Francis about compassionate care that really played out in the HIV/AIDS epidemic when the role of palliative care became so critical, as it will be as we expand our work on cancer. On the positive side, the writings of Viktor Frankl, surviving Auschwitz, remind us that even in the darkest time, the missing element of meaning and hope can drive people's survival and quality of life even amidst the deepest despair. And he went on then to found the field of logotherapy focused on cancer therapy, but the implications are just as much for people with advanced diabetes care or the need for prevention. Next slide. We know that the scale of faith-based organizations are high, and I won't repeat what people said. Just one point that I think is interesting, coming out of a Lancet review, where they made it very clear that faith-based organizations don't just provide a lot of care, they serve the highest percentage of the poorest quintiles and concentrate in remote and underserved areas. Certainly CMMB's presence in many of the refugee areas, many of the displaced populations is an example. We also know that they provide a lot of the pharmaceuticals across the continent. Meds Kenya, for example, providing 40% of the national pharmaceutical supply, and deeply embedded in their philosophy is one of faith. I do think that we need to look more carefully at the AIDS precedent, and I was really very excited in speaking to Nate about his early work, both with CMMB and in AIDS, recognizing the power of faith-based organizations as trusted deliverers. Well, let's think about how we can actually now translate it into the areas of chronic diseases. And what that will take is very pragmatic clinical skilling. We need to ensure that faith-based organizations, the health services, have the capability to navigate cancer, to detect and treat mental health. They need to be able to be linked to the supply chains in ways in which we've made incredible progress on HIV/AIDS, meds being one example. We need to think about how faith-based facility capacity can be embedded in the access to oncology medicines, a big network that's been created that tends to focus mainly on governmental services. The same is true with WHO. Next. Next slide. I mentioned that it's not just the trust of the faith-based organizations that matters, but it's the fact that faith-based organizations at their core believe in a set of spiritual values, that there is something greater than us that helps us find meaning and purpose, that there is a way to, then that drives people's focus and improves their survival. In doing that, it's particularly important to show how with mental health, we know that without meaning and purpose, we see depression, schizophrenia, anxiety rates rise very fast. So much so that, believe it or not, the McKinsey Health Institutes, in their large review on spirituality, recognized that what was missing wasn't more medications, but a greater focus on the spiritual dimensions. We know how important that is, not just for infectious diseases, but for acting as a hub for blood pressure screening, diabetes screening, or advocating for healthy lifestyles, ending smoking, physical activity, and so on. In the area of cancer and palliative care, as I said, we must never forget that 70% of people diagnosed in cancer today in Africa will be stage 3 and stage 4. That really creates an obligation to do what we did with HIV/AIDS, to provide dignified palliative care using the highest quality of support. I was really so emotionally and I'd say even spiritually encouraged by what I saw in Tui in Kenya recently, where at their cancer center, the nurses were clearly trained not just in getting the chemotherapy out, but in also providing the chaplaincy services to so many of the people who desperately need them. So let's turn to the last one. Way back in my WHO days, I had a very strange task, and that was to relook at the definition of health, which, as you know, says that health is not just the absence of disease, but a state of complete mental and physical health. Well, a number of countries approached us and said they wanted the word spiritual to be included in the definition of health. The whole story about that was written up quite recently by the professor of religion in Zurich, Simon Penkeller, and this book really is an inspiring book about decades of trying to get the word spiritual included, not because one word matters, but because it brings on board all of your work in the faith-based organizations and gives it legitimacy and makes people recognize the value of the spiritual beyond just the physical. Something, by the way, that was highlighted in the very first World Health Assembly of WHO in 1948, when the Swiss delegate got up to say what should WHO stand for. He stressed it should address both the material and physical needs, but also give support to the spiritual and deeper needs. I think particularly in our African colleagues and institutions, while access to material resources to address so many of the issues related to cancer and mental health will take time, hopefully not too long, spiritual resources are already embedded in every community and ready to be deployed if we think about how we can focus them more explicitly on what is the rising toll of death, disease, and disability, namely non-communicable diseases and mental health. I look forward to your questions. Thank you.
Thank you so much, Derek. Now, thank you to all of our presenters. Now we have a number of questions in our Q&A, and we will, in the time that we have, we'll address as many of these as we can. The first one is from Neely Hicks. Harper Hill Global equips and trains faith-based communicators in Uganda and DRC to prevent Ebola and other diseases using media, radio, WhatsApp, automated SMS, and television where applicable. How can we connect and coordinate our efforts with CUAMM? Emanuela, I think that question goes to you.
So I think that the answer implied taking in mind the different challenges that I mentioned before, because to manage outbreak and then pandemic, faith-based organization managing healthcare facilities have first of all to improve and strengthen their healthcare workforce, training healthcare providers, but also implement the partnership with governmental institutions acting at not only at a local but at regional and national level. And to implement the relationship with other institutions, other faith-based institutions, but also with national healthcare institutions. They have to implement a data collection process and the sharing of data to make more visible their work and their social embeddedness with the population.
Wonderful. Thank you, Emanuela. We have another question. It's an established fact that faith-based organizations undoubtedly foster trust in health systems, but please also discuss possible risks attributed to this trust, particularly from the perspective of resources management. And Dr. Gobir, perhaps you could address that from your perspective.
So from my perspective, with regards to looking at finances, I had a conversation with a faith leader recently, and the conversation actually landed in asking me directly, will I give my money to a faith leader to help drive a particular intervention when we were discussing maternal and child health? And the answer to that in addressing this question is yes, faith leaders can be trusted. And the reason why they can be trusted is because a lot of these faith leaders back the trust conversation around what you have in the scriptures. For example, in Islam, you back it up with what you have in the Quran. The best you can do is to continue to preach to people and talk to people around why they need to uphold, the teachings and the tenets of the Quran that talks about how you manage resources. That is something that traditionally we don't have in the formal sector, because you have all of those decrees, you have the laws, you have everything there, but there's no one to actually reinforce or emphasize that to people. And the ignorance of the law typically is not an excuse. On the contrary, from the perspective of the faith sector, when people go and they go to pray, they go to practice, these messages are being reinforced. Now, outside of reinforcing and backing it up with what you have in the scriptures or in the Quran, the rest has more to do with, what all other traditional institutions would put in place to ensure accountability and resource management. So to summarize, really, the faith structures is continuously being reinforced with the scriptures. And most people believe that no matter what you do, there's another afterlife, there's that eternal life, and they want to be able to, get to that space apart from even just whatever we do today. So that's my response to that. Thank you.
Thank you so much. I have a question here for Dr. Njeru. I would be interested in hearing how to address the competition between social media misinformation about health and trust in health interventions and services that faith groups can assist with. Nkatha, was that question clear? Looks like we may have lost Dr. Njeru.
I have unmuted. Sorry
great.
about that. So I would say this is not just a simple competition between social media and misinformation. The really issue here is misinformation often travels faster because it speaks to people's fears, their questions, and their lived experiences. And I think what we can do, we are powerful not only as messengers, but interpreters of meaning. And we can help communities by ensuring that we equip faith leaders early enough with the accurate information, and also use these same channels where misinformation is spreading. We need to be present on WhatsApp, on Facebook, on TikTok, on every place that this information is. And before we speak, we also need to listen and understand what is being shared. Communities need to have safe spaces where they can express their fear. And there's also need to connect these messages with action. How are we as faith leaders, as faith actors, encouraging communities to seek treatment? What are we doing ourselves? Are we also creating visible partnerships where communities are saying faith leaders and faith-based health systems working together? I think there's an opportunity not just to counter the misinformation, but to ensure that we build a trusted communication ecosystem where the faith leader, the health worker, and the community are in continuous dialogue. Thank you.
Wonderful. Thank you very much. We probably have time for maybe one or two more questions. Here's a general question, really for all of our panelists. How do we engage patients who do not have any beliefs or faith that they identify with? And I open that up to any of you who would like to comment.
Nate, I think, this is Derek here. I do think that Viktor Frankl's writings provide us with some inspiration about how one does that, because he writes explicitly about, in the context of cancer, people struggling either with an early diagnosis or treatment and not having a particular faith. But the challenge, he always said, was to define what was important in their lives, what brought them meaning, what brought them purpose, what was it that they wanted to have for the next day, either in terms of a goal with the family, a goal with a higher being, or some greater presence. So I think a lot of the faith-based teachings about promoting spirituality and health don't require you to have a particular religion as your backbone, and actually apply to all people.
Thank you very much, Derek. Excellent response. I think I'll slip in one more question before we close. Could any of the speakers please comment on the capacity of faith organizations to provide palliative care? The International Association for Hospice and Palliative Care is building a global interface advocacy network to build faith leader literacy in palliative care to support community health. Please advise us on how we might best proceed.
I don't want to take too much of the time, but I do think that this lies at the core of what was achieved during the HIV/AIDS epidemic. As you know, Nate, before we had antiretrovirals, the only really major thing we had was to provide hope about the future beyond your physical life. And the expertise developed on palliative care in the AIDS community has enormous application. I mentioned it's now being applied in the area of cancer and cancer control. The work, as I said, of Viktor Frankl explicitly addresses the issues of palliative care. And as a multiple survivor of many cancers, I personally look at some of this work and understand that the starting point always is to help people think about what is the most important thing that brings meaning to you in your life, regardless of your stage of disease or what's happening to you. So there is a huge body, and I would certainly be more than willing to talk to them about this as well. And sorry, I would also refer back to the Institute for Spirituality at Texas Medical Center, where there's a huge training program for chaplains that go out across the US. And I know that this is one of the core elements that they all address.
Thank you, Derek. And thank you to all of our presenters. These have been extremely helpful and informative and complementary presentations. And my regret is that there are so many other good questions that have been submitted by our participants that we've not been able to get to. But thank you, panelists, for addressing these really good and important questions. I want to thank all the participants, especially those who submitted questions. I want to thank again our panelists for their excellent presentations. And I'd like to invite all those who are participating to stay engaged with the Georgetown Lancet Commission on Faith, Trust, and Health through our website and our newsletter. Links are provided in the chat, and our webinar series will begin again in a few months. Thank you to all of you.